So we'll be having Dr. Satyamurthy now to speak to us on anti-segment foreign bodies. Dr. Satyamurthy is Director of Cornea Refractive Surgery and Eye Bank in MM Joshi Institute, Hubli. And he looks after he's a medical director of the Dharwad branch of MM Joshi Group of Hospitals.
Thank you, sir. At the outset, I would like to thank Dr. Guru Prasad for giving me this opportunity. In fact, corneal foreign body, anti-segment or any foreign body for that matter is an emergency, and it should be treated at the earliest. So foreign bodies can be inorganic and organic. Inorganic, it can be metallic and non-metallic. So I'll not go into these details as they are depending upon the speed at which the foreign body hits the eye. It can be either on the surface of the cornea or it can enter the anti-segment, as you see the things clearly here. Now let's see one by one. What if it is on the cornea? If it is just loosely laying on the surface, then probably all that we have to do is just wash with saline or using a magnetic spud or a cotton bud, we can remove it. Sometimes it is embedded deeply into the cornea. It goes, if it is below Bowman's membrane, then that will result in scarring. At the same time, there is something called as a Coates white ring, as you see here. That is nothing but the iron, say in a metallic foreign body, this is an iron piece. So the iron and the fibrotic remnants which form a grayish white circle around the foreign body, and then unfortunately this doesn't disappear even after removal of foreign body and treating with steroids. The foreign body can be removed as you go obliquely in an anesthetized sac and then take out the foreign body. I will not get into this. Now, what is most dangerous is this rustring, what you are seeing here, that has to be, especially ferrous foreign body, it will leave behind rust 4 to 6 hours after the impaction with foreign body. The rust starts and that has to be removed. Otherwise, patient will be symptomatic and epithelium will never heal in that area. So that has to be removed. All that we have to do is just remove the edges and then peel it off with a forceps, or one can use a brush, the corneal brush. Yeah. Now the problem is, what if there is a central foreign body? Why I am saying this? Because if the foreign body is in the superficial stroma, and then it forms a scar there, and then along with that white ring, and if we try to remove the foreign body, as you see here, and try to dig too much into the cornea, then we are going to leave behind a central scar which can hamper patient's vision. So one has to be very careful while doing this. In case if we don't follow any aseptic precautions properly, our patient may present with an ulcer like this following fall of foreign body. Like in the previous session, talk, Dr. Aniket showed a very nice multiple foreign bodies started on the cornea. This is what you get following blast injury. And all the superficial foreign bodies you can remove. Deeper foreign bodies, in case if they are inert, like glass pieces or something, we can leave behind. Otherwise, removal itself can cause a lot of scarring. And so we'll have to observe this patient regularly. And now this is a case where the patient came with foreign body like this. And no, play it, no? Why it's not playing? Yes, right. You see a foreign body there at the limbus, the peripheral cornea, and then it was removed finally. Since it was through and through, one stitch had to be taken. Already the infiltration had started, so put this patient on intensive antibiotic therapy, topical antibiotics for a longer period, and one has to do CDL test in every case of foreign body to make sure that the foreign body is just, it is not, whether it has entered or not, or the corneal wound is open or not. So now this is coming to the next This is a vegetative foreign body where it's quite common because most 70% of the people, they live in rural areas and they come with this kind of thing, maybe a sugar cane or some wooden piece which has gone inside, especially in the farming community. All you have to do is just make an opening at the fag end of this and then take it out with a forceps like that. And at the same time, make sure that by Seidl's test, this track is not open. Okay. Right. Thank you. This is another case where you can see this. There's a foreign body inside, and then you can see the lamellar hole, lamellar tear there, and then the track is opened, and the foreign body is taken out. This is a vegetative foreign body. And then so here there's a caterpillar hair, which you can see. I mean, this is the hair follicle, which is stuck in the cornea, which is removed like this. And now, Dr. Aniket showed beautiful slides on this particular thing, ophthalmia nodosa, following the injury with caterpillar hair. So now let me just go a little deeper into this particular field. In fact, you asked a question where the caterpillar hair can cause vitritis or any post-segment complication. Caterpillar hair, which is otherwise called spine or setae, it has got that hollowness in which there is a venom, and the spicules, which are the thorns which are directed upwards towards the distal end. So the caterpillar hair is known to migrate deep inside. So whenever the patient comes for follow-up, some may disappear, but some, if they have disappeared, they might have entered the post-segment also. That is how patients may come back with quite anti-segment, but vitritis. Ophthalmic nodosa is a very known entity. Of late, it is coming down, but it is more common in those people, motorcyclists or those who ride bike without helmet or without any eye protective glasses. It can appear like this, or sometimes there is, superficial superior corneal aberrations where the answer lies on the lid. You have to avoid the lid, and it was beautifully shown by Dr. Aniket. Removed a lot of those things. Sometimes bees, this is what is the Hymenopteron group of organisms, that is bees, wasps, and then biting ants. So they cause problems by hitting the eye. So if you see here, this is the stinger, and then the bee, when it hits the eye, it leaves behind the stinger and venom. So the venom will contain histamines, and it will contain what is called a melittin, which increases inflammation in that area, and then hyaluronic acid, which allows it to spread. It may look like corneal abscess, but it's not so. All the mainstay of treatment is, one is removal of the stinger. Second thing is, you'll have to treat with steroids, topical and oral, intensively. So it can present with diffuse corneal edema, or it can present with cataract also. It can present with anti-chamber reaction. Sometimes the endothelial decompensation may start. It may not yield to your treatment. So in that case, you probably will have to resort to graft, endothelial grafting. So now this is another case where the foreign body was lodged in antechamber. So it was removed by making an incision here, as you see here, and then the whole thing was removed. So any foreign body, if it is visible, it is always better to remove that. And then now coming to foreign body which is lodged in the angle, one should have high index of suspicion, like Dr. Guru Prasad said it multiple times, because foreign body in the angle is not visible, and sometimes you may miss the track in the cornea or in the peripheral cornea or limbus or sclera. Then many times you will have to do gonioscopy, and then only you will come to know that there is a foreign body. X-ray per se may not be a very sensitive thing. It is said that about 40% of these foreign bodies are seen on X-ray, even though it is radio opaque. but otherwise you're likely to miss. So what is more important is this CT scan, which definitely, which is very highly sensitive. And then of course you have UBM, but you can't do UBM in every case. So the gonioscopy is a must in all these cases. And now the foreign body which can enter the eye, if it is say ferrous foreign body, that can cause siderosis like this, what you are seeing, or it can cause traumatic cataract. I'll show you a video on this. So thanks. I'm thankful to Dr. Kumar for sharing this with me. You can see that is the foreign body, and there is another foreign body which is seen deep inside. Okay, so probably it has hit and gone just into the lens, and it has not pierced the posterior capsule. So this was removed using magnet probably, and then finally the traumatic cataract was managed, and then intralenticular lens was. So this is just to show that foreign body can enter like this, a large foreign body through the cornea from limboscleral to the corneoscleral on either side. And then as you see here, it's been a little difficult to take it out, even though it is protruding out. Yeah, this is my last slide. So this is the foreign body which is there. So I would like to conclude by saying proper management strategy is very, very important. And of course, a high index of suspicion in those cases where eye is irritable, and you'll have to rule out the presence of foreign body. And then, of course, appropriate investigations are to be done. Thank you very much for your patient listening.
Thanks, Dr. Satyamurthy. Just one question I have, and then we can probably ask the audience also to participate. In cases where there is a foreign body that is more into the posterior cornea and the antechamber than on the surface, so do we dig into the cornea and bring it out from the external approach, or should we remove it from the intracameral route?
Fine. So it's a very good question. So now that foreign body to enter into the antechamber, I mean to the cornea, and from cornea protrude into the antechamber, there has to be a track on the cornea. So all that we have to do is open it and then make a paracentesis wound and put a lot of viscoelastic, dispersive viscoelastic, where you can protect and you can push the foreign body up. That is the easier way of removal thing, and then later on you can remove the viscoelastic. This is what I do. In most of the cases.
I think we can make it case-based, depending on
Yeah,
how
that's
much
what.
of it is inside and how much we can
That time you
access
can just
from
on the
outside.
table, you can take a call and then do it.
Thank you,
Manage
sir.
it up.